Good evening, class. We're going to spend a few minutes tonight talking about technology transfer in healthcare. But before we jump into the technology, transfer issues, I want to go back and review just a little about what we talked the last time we got together when we were talking about the healthcare workforce market. And we spent our time, as I said, in the session last time, talking about either physicians or nurses, the two main components that drive the I guess you could call it the healthcare engine, especially on the provider side. And to a certain extent, they're very influential on the payer side also, but mostly on the provider side is just where they really drive the engine, even though there are some other individuals, some administrative staff, some technical support, some you know technicians especially that help on the floor to take care of patients or help in the doctor's office. They kind of help you not only flow through the system in the doctor's office, but to improve efficiency and allow physicians to see more patients at any given time. We also talked about it's basically expectation of future revenue that drive a lot of physicians with regard to going into the healthcare environment. And it's the same with nurses. Nurses, especially if you were going into the nursing environment now, it's a very lucrative environment to go into right now, and it's a great opportunity for both men and women. So it those are your two big components. Nurses, for the most part, at least in most communities, are somewhat unionized. Physicians, you don't typically hear them talking too much about unions. And then the other big difference is the lag time, or the amount of training and education it takes to go from a freshman in an undergraduate degree to a functioning physician that's out in the marketplace is significantly longer than it is with a nursing degree. And those are two variables that impact the ability to eliminate either surpluses or shortages in the healthcare market. And before we go on to the technology transfer, I want to just spend just a few minutes. We talked last time, or at least I talked last time, about price being a driving factor, and prices are, for the most part, whether it's CMS or TRICARE or Medicaid or even on the commercial book of business, mostly set on an annual basis. So negotiated, Q4 of a year, they go into effect January the 1st, and those rates or those reimbursement payments will be in effect all the way through until they're renegotiated again. And so in the negotiation process, it becomes extremely important for those on both sides of the negotiation. And again, it goes back to both sides of that financial coin, for both individuals on the sides of those negotiations to understand the process and understand what the expectation is. Remember, the negotiation process, providers are wanting to maximize revenue, so they want to maximize the rate that they're paid. Payers are wanting to minimize expenditures, so they want to minimize the rate that they have to pay for those healthcare goods and services. And if you think about it, on the health plan side, so if you're negotiating on the health plan side, you have information about all of the provider groups that you have negotiated with in a given geographical market, and you've sat down with your actuaries, you've sat down with your financial analysts, you may have even reached out to some external actuarial, consulting firms, and you've developed a potential kind of negotiating strategy on how you're going to approach these negotiations. And as you approach your negotiations, you're going to actually set on the negotiation range, you're going to set the upper limit. You're going to set the highest price that the health plan would be willing to pay. And you know that going in, here's the most I can ever pay for a good or service based on what we're paying other providers in a general locality. Now, the flip side of that financial coin, if you're working on the provider side, you're setting the lower limit of that negotiation range because you know, based on historical information, what is the lowest dollar or the lowest amount of money that you're going to accept from a payer for providing healthcare goods and services. And you have information, not so much from other provider groups, but you have information for your group on what every other health plan in the local area is willing to pay for your goods and services. So the health plan sets the upper limit, the provider sets a lower limit, and all of the negotiation in between is driven by asymmetric information. Providers know what all the other health plans are willing to pay. Health plans know what they're paying all of the other similar providers in the area. And so this asymmetric information and the asymmetric information during the negotiation process, if you're a really good negotiator and you really pay attention, you'll be able to ferret out some of the information that one side or another has. So if you're on the provider side, you'll be able to understand where the health plan's coming from and what they're basing their information on. If you're really good on the health plan side, you're going to be able to ferret out what the provider's basing their negotiation strategy on. So at the end of the day, it's this asymmetric information that's going to drive the success of an individual negotiator within this healthcare negotiation range. And at the end of the day, from a financial perspective, the one that is closest to the other's limit is going to win the negotiation. So if I'm the health plan, I want to be as close to that lower limit that the provider has set as I can. And if I'm a provider's negotiator, I want to be as close to that upper limit that the health plan has set. And it's working up and down in that negotiation range that's going to end up driving the ultimate contractual rate. And one last thing that I will throw out there before we move on is you hear a lot of times on the, especially consultants will talk about, and I can't remember who came up with the initial quote, but when they're talking about physicians, they'll say the pen is mightier than the sword. And that is true on the physician side or on the provider side, because what those providers are writing in the medical record, what kind of pharmaceuticals they're providing, what kind of referrals are they, if it's a primary care doc, who is that primary care doc? How are they referring individual patients out to radiology, laboratory, other specialists for, consults and additional information? So depends on what that provider is writing on in that medical record and what that provider is writing on all of his or her referral scripts. That's why they say the pen is mightier than the sword. So that kind of brings us up to technology transfer. And when we're talking about, when you go back to your micro classes, technology referred more to the process that firms use to change inputs into output. What we're talking about here in technology, while it is somewhat similar because it's the automation, the innovation, the technological advances that help improve that production process from beginning to end, we're looking at it more as individuals that are developing software packages. Maybe they're developing new medical techniques. Maybe they are developing new medical devices. All of this kind of falls in that technology sphere in what we're going to talk about today. And again, if you're following the notes that I put out there, if you look at the first bullet, it says impact and benefits on rising costs. Cost containment might mitigate the rate and implementation of technological change. And where Dewar is going with that is the question becomes, who's going to pay for all this technology change? Is it going to be provider side of the house as a sunk cost, as a fixed cost of doing business? Is it going to be on the payer side of the house through the reimbursement rate or through the negotiation strategy? Somebody's got to pay for it. And that is the rub right now with these huge changes in technology that we have seen over the last few years. I mean, they have been exponentially changing, and And not only is it improving patient care and at least potentially improving outcomes, improving the benefits that you see as an individual, or the utility that you see as a consumer. But at the end of the day, who's going to pay for it? And it's going to become more and more important, because as AI and the artificial intelligence and the machine learning start to take over, who's going to pay for that? And while it may be improving outcomes, and it may be improving quality, and it may be improving just the participation of a consumer within that healthcare environment, somebody is going to have to foot the bill on this and have to, I guess, pay the freight on all of these technological advances. And that's got the healthcare industry worried at this point. Technology, sophisticated healthcare. The author talks about overall demand, improved access, marginal improvements in treatment outcomes, rising costs, efficacy of treatments, malpractice, and litigation. And if you start thinking through some of those, it's almost, I can't remember the last time that I went to the doctor's office that I didn't have to take and get on the internet beforehand and type everything in. They're basically using the electronic medical record and the software package to check you in. They're getting your credit card information. They're getting, asking you, are you having any issues, or talking about medication. All of that's going, through technology and automation. It's populating that, electronic medical record that you have, so that when you get to the doctor's office, you still have to show them your credit card. At least I do. Show them your credit card, show them your driver's license, so they can prove it's you, and then you're done with the check-in. Kind of a seamless process, and it's kind of to me, it's kind of a pain in the behind, because they don't keep the information. So every time I go to the doctor's office, I'm filling in my name and my street address and everything. So don't particularly like that part of it, but I do like the streamlining of the process. And then once you get in the doctor's office, they're asking you questions just to validate or verify that you understood the questions they were asking. What's happening, though, is all this technology is driving the rising cost of healthcare. And they talk about the efficacy and the marginal improvements in treatment outcomes, but more and more payers especially are concerned about the rising cost. There is some argument that healthcare, especially as a litigious environment, and at least the technology improvements might help to reduce the number of instances of malpractice and reduce the number of instances of litigation. And the third bullet is this: the text and the authors talk about technology has been the largest contributor to higher prices and cost of healthcare. And one thing that you see, especially on the provider side, is individuals, and they can be vendors, they can be salesmen, depending on who's, I guess, servicing the doctor's office. What you will see is they are actually going in and selling their goods and services and teaching providers how to maximize their revenue by changing their billing policies once they get, maybe it's a new piece of equipment, or maybe it's a new software package. So that's actually increasing and I'll call it, revenue creep in healthcare. So providers are, I don't want to say, but most providers that are engaging in this are, while it's within maybe the guidelines of accurate billing and coding practices, they are playing with the system, and they are maximizing revenues by learning new ways to bill once they get this new piece of equipment. And it says technology advances via innovation. And this is where they talk about Schumpeter. And Schumpeter was an Austrian economist. He was replaced, or at least Austrian economics were replaced by the University of Chicago and that group of economists in, I think, 73 or something. I don't remember the exact date, but Schumpeter viewed innovation as the driving force in a market economy. And he coined the term creative destruction. And through innovation, when he talks about creative destruction, he's talking about out with the old, in with the new, out with the inefficient, in with the efficient. And his argument was that entrepreneurs looking for increased profits, are improving innovation, creativity, technology, and they're taking old, outdated technology and replacing it with new, improved technology. And that process continues over and over and over. And that's why he refers to it as creative destruction. You're destroying the old, you're creating something new that is better, and you're replacing the old with the new. And he also talks about the driving force in the economy. It's not only creative destruction, it's profits and it's market power. All of these technology firms are looking, they're wanting to maximize profits, and they're trying to do that through increased market power. One of the things that technology drives, and you can go back on technology and think about laparoscopic surgery, you can think about robotic surgery, and it's supposed to be much more accurate and generate higher quality outcomes. But again, who's going to pay for it? And a lot of these, especially hospitals and some of your larger medical groups, are using technology to recruit physicians, especially in orthopedic surgery and neurology and cardiology and some of your cancer treatments. And it's all being driven by professional prestige. They look at it as they're eradicating disease. The policymakers are looking at social and welfare economics, and that's driving the government funding. And it's also being driven by changes in technology. Now the first bullet on the next slide, they're talking about who's driving, the research, and it's NIH, National Institutes of Health. It's teaching research universities. It's a National Science Foundation, and that's the acronym NSF. It's private industry drives research, and of course, private industry is driving because they're looking at it as future profits. They're looking at it as long-range profits, especially if they can get a patent or a copyright on it. It's mostly a patent on this healthcare types of improvements or technology. One thing you have to be careful about when it's like NIH and NSF is, who owns stock in these companies? There were questions with the NIH in COVID. It was like NIH was, somehow driving the bus during COVID, but a lot of questions on NIH is, what was the rationale for them to be driving the bus? The demand for products and products expectation drives innovations. Now, there could be some issues with price controls may dampen the desire for research and innovation. And I think where she's going with the price controls, especially if there are market deficiencies, the government, because they think they know what's better for us than we know ourselves, like to dabble and like to get in and play in the markets. And they rationale for them, they would say, well, it was market failure, and we decided we needed to step in. And that may be the case at some points, but if they put parameters in there that reduce price, so let's say it's CMS, Centers for Medicare and Medicaid. They're in there and they're setting their fee schedules, and they may decide that under CMS, for Medicare and Medicaid, they're just not going to pay for it. You can bring all the new technology in you want, and you as the provider can eat it as a fixed cost, and they're just not going to pay for it. And then you have a lot of commercial plans that that a lot of times will default to CMS guidelines when it comes to paying the tab on some of this technology. So the government could, I guess, play in the market to the extent that they can dampen the acceptance of new technology because they're trying to control the price on it. Patent protection, gives you exclusive ownership for intellectual property rights, 20 years for drugs and medical devices. But by the time you get through the testing period, it could trim that down to 12, 10, 8 years that you can actually, as a company, generate profits from this new drug or this new medical device. Imitation is costly to drug companies because of the developmental costs. So if you've ever gone to the pharmacist, they'll ask you for your prescription, do you want brand or generic? Well, brand drug is covered under the patent. Generic is when the patent expires and now everybody jumps in if it's a drug that they think are going to generate profits, and they start generating these generic drugs, which for the most part um, do a fairly decent job when it comes to the treatment plan. I personally, there's some drugs I take. I take a Z-Pak um, for my sinus infection, and I just soon have the generic Z-Pak as the brand name Z-Pak, because actually I think the generic does pretty well. Individuals that may be taking thyroid medication, some of those individuals find that the brand is better than the generic, and they'll actually pay a premium for the brand just because they think, or at least they have the perception, that it does a better job. Um, and if you've ever been to Southern California, especially over on Torrey Pines Road, and then you've got the Torrey Pine Golf Course, and it looks out over the Pacific Ocean. I mean, it is a beautiful view. And that's where all your technology firms are located. There's a lot of money going to technology and trying to generate patents. And they build these, elaborate offices over on Torrey Pines. So, the individuals, when they're not working, if they give them a break, they can, actually go play golf at Torrey Pines Golf Course. They can, have a sandwich and something to drink and look out over Pacific Ocean. I mean, it is a fantastic view, but it just goes to show you how much money there is in these technology firms. The U.S. is a world leader in biotechnical technology because of human capital. Look at how our individuals individuals coming out of college are trained here. Great research institutions. You've got patent protection, again, 20 years on drugs and medical devices. You've got third-party payers that, look, I mean, you've got health plans that they will pay for some of these advances, especially in drugs and medical devices, if they think it's going to help them on cost containment and improve quality of care. They're more than willing to pay for some of these. Now, when it gets to be an excessive price on it, they will kind of balk at it or backtrack. But as long as they think it's affordable and fits into their cost containment policies, the health plans are willing to pay for these types of advances in technologies. And then you've got, provider motivations and provider profits. Again, in the United States, we're a free market economy. Firms are in the business to make money, to generate profits. And because they're in the business to make money and generate profits, it incentivizes that entrepreneurial focus of individuals here in the United States. I saw it not too long ago in a textbook I was reading. They said they quoted and said, entrepreneurs like bloodhounds. They can smell out a profit opportunity better than anybody that they had ever seen. And that's what drives this innovation and creativity. It's the search for those elusive profits by the entrepreneurs. The United States ranks highest in technological diffusion, given complementary support and human capital. When talking about technological diffusion, they're talking about getting it out in the market and having individuals buy the new technology, and it goes into the processes of these individual firms, these individual healthcare firms. Economic incentives, fee-for-service reimbursement, and fee-for-service means, as we've talked about in the past, you're going to get the provider is paid based on the types of services he provides, drives the rate of technology diffusion. Fee for service and prospective pay for service and prospective, payment for service means the rates are developed ahead of time and everybody agrees on them. They have varying impacts on the diffusion of technology. It's difficult to manage the impact of healthcare costs and treat it as a residual. And in Princeton, I've had that SOLAR residual, and that residual, it's empirical growth in economy year over year and decade over decade. It's a number. It's a residual number. So they are trying to, when you're trying to determine, as an economist trying to estimate or forecast what the impact on healthcare cost is, they actually treat it using this SOLAR residual formula, SOLAR residual calculation. and they treat it as a residual. Incentivized cost and quality increasing technology, it was until the mid 80s, and that's when um, cost of the technology started to really jump. It was definitely increasing at an increasing rate if you look at the chart. And that was because until the mid 80s, a lot of your healthcare, a lot of your health plans were paying for healthcare goods and services. They were just paying cost or paying bill charge. Whatever the provider submitted on an itemized bill, that's what they paid. And so providers, you're talking about a gravy train. Providers were grabbing all of this new technology. It was improving internal efficiency in their offices or in the hospital. And they were just turning around. And not only were they making economic profits, but they were turning around and they were just passing the cost on to the payer. They weren't too concerned about what the cost in technology was because somebody else is going to put the bill on it. Process innovations, when you're talking about cost savings. Product innovations, you're talking about cost increasing. Discounts, quality, and mortality rate while concentrating on total cost. That is the name of the game, especially on the payer side. It's total cost. Not only on the payer side, but think about the employer groups now that are starting to assume responsibility of the cost of healthcare. They want to be responsible for the cost of healthcare, and they're administrative service, organizations, ASOs, and they are paying, health plans to develop a network, process claims for them, to provide them some medical management, and they're paying an administrative fee, and they're taking all the risks. So that employer groups are going to be concerned about increasing costs. And then lastly, on this page, it talks about first and second generation technology versus halfway and high technology. And, basically that just means cost change as one processes through the innovation cycle. So if you're going through the innovation cycle, costs are going to change as you move through that innovation cycle. And then the last page, it's talk about productive efficiency compacts the quantity of inputs to produce a given output, allocating resources to capital capacity and technology. And again, it goes back to laparoscopic. Laparoscopic, better outcomes, robotic, better outcomes. It's just the cost. Who is going to foot the bill on the cost? Costs are driving things. They're not, providers on the provider side. You're concerned about efficiency and in the production process and taking the factors of production and turn them into outputs. On the health plan side, we're really if you're on the health plan side, as I spent most of my career, you're concerned about the cost. Health plans are trying to bend that cost curve. They're trying to bend the impact of increasing cost in healthcare. They're trying to develop management strategies that are going to help mitigate the rising cost of healthcare. Some are good at it, some aren't so good at it. But that's one of the driving goals on the health plan side. And that's why when we have the financial coin and the two different sides, that's why everything's at odds with each other. Providers maximizing revenue, health plans trying to minimize costs. And the last bullet that on the handout, this is the driver, and this is probably the summarizing sentence on this, discussion of technology and technology transfer is cost containment strategies will impact innovation in the future. Again, who's going to pay for it? If nobody's going to pay for it, or they're going to pay a rate where the marginal revenue is not greater than the marginal cost, it's going to dampen creativity, it's going to dampen innovation, and it's probably going to dampen the diffusion of technology going forward in the healthcare marketplace. Fairly short section on technology. Only one video. Usually I'll do 2 or 3 videos, but only going to do one video on technology. It's an extremely important aspect of the healthcare market. But it almost boils down to that last bullet on the handouts or the notes. It's cost containment healthcare costs are just astronomical in the United States, astronomical healthcare costs, and maybe the outputs aren't what they should be. And so going forward, it's going to take everybody, that whether you're on the payer side of that coin or the provider side of that coin, it's going to take individuals and firms working together to try to control this healthcare cost, or it's just going to continue to blow through the roof. That's going to wind us up with this particular topic where we're talking about technology transfer. And I'll see you again soon. Thanks for joining.